type of joint pain, indicating that there's something joint pathology-wise going on, meaning osteoarthritis, some type of cartilage issue at the joint. So we're going to just bring her up to a 90-90 type position, and then I'm going to just compress. So I'm compressing down, and we've got two motions we're going to do. We're going to just externally and internally rotate, and really the internal rotation would be the caution, because that's where if they have a lot of arthritis, we're likely going to see a problem, because remember, internal rotation is restricted. All right? The other thing is called a scouring sign. It's the same thing. I'm not going to press down right now just to show you, but basically we bring her up, and we kind of do like a half moon type of shape of kind of adduction and internal rotation. So we're kind of like that. So it's kind of like this scour, again, this compression, and I'm kind of just going like this. Again, as I said, it says be cautious on there. So let's say she came in and her diagnosis said hip osteoarthritis. I don't know that I probably wouldn't do this test. If she already knows that she has hip arthritis and she has an x-ray, this is going to hurt her, right? And then arthritis is all about getting flared up. So I could flare it up or agitate it. So you'd say, when would I do this? If a person came in and they seen their general practitioner and the script said hip pain and they hadn't had any x-rays and they didn't know, this would help me decide, do I think there's an arthritic or joint component to it, okay? So that's a quadrant sign or a scour test.
When you compress, are you compressing
Straight
like at the hip or at the knee?
I'm pressing down through the knee, but I'm basically trying to shove the femur into the acetabulum. So I'm pressing here, but so I'm not. I'm definitely not. I'm not doing this. I'm doing that, right? Pressing down like that, right? So 90-90 is just a hamstring tightness. We've kind of done this before. We'll probably look at it again next week because I'm sure it's a length test for the knee. But it's just, wow, some popping going on there. So 90 degrees at the hip, 90 degrees at the knee, straighten it up. Again, she's feeling some tightness, but it's technically a negative test because she basically goes 20 degrees or less is negative. Now again, same thing. I could call it positive if it's really something she needed to work on. If she's right at 20 and I think hamstring tightness is one of her issues, I would still call that positive or at least indicate that I want it to be worked on. We'll skip Trendelenburg for right now because that's a standing test. So we'll have you do this apparent leg length discrepancy. Again, right now, all I want you to know is it's a test that we're going to cover a little bit more next year, next semester when we look at the SI joint. But basically, I think the other thing that I haven't covered that I try to cover, again, we want to be clear if we tell them there's a leg length discrepancy, that we think it's an apparent leg length difference, especially if they've had any kind of orthopedic surgery. There's nothing worse than telling a person they have a leg length discrepancy and then going back to the orthopedic surgeon and saying that, because that's not what we're saying. It's an apparent leg length discrepancy, likely because the SI joint is kind of mobilized. So I over-explain that so they're very clear. I'm not saying your bones are different length. I'm saying something's going on in a different part and it makes it look like your leg is different. You got to be very clear on that. If you want to get an orthopedic surgeon calling, asking for the therapist that treats them, roll with that, see what they say. So this test is simple as we want to make sure she's pretty lined up, right? So we don't want her crooked. That can make you look different. And one of the ways we clear that is we just have her bridge. So lift your rear end in the air, and then she brings it down. And then again, we don't want to look at your shoes. Almost everyone says that, and then almost everyone does look at their shoes. But we're kind of bringing her in and kind of seeing where she's at. We're going to look at something a little more stable, like her bone. Again, it doesn't matter. You can hook the top of her medial malleoli. You can come under the medial malleoli. You can look at the peak of her medial malleoli. You just want to make sure it's consistent. You want to make sure that you're looking with your dominant eye. So meaning you want to be right over the top of it, looking down at your dominant eye, see if there's any asymmetries, all right? So it's just looking straight over the top and seeing. And again, the asymmetries would be one thumb is higher or lower than the other, indicating there's a leg length discrepancy. Then we come up. We usually go to somewhere in the knee. Again, we could go the top of the patella. We could do tibial tubercle. Again, I'm going to get right over the top of her, and I'm going to look there. And then we come up ASIS. I'm going to find her ASIS, and I'm going to find the other side. And again, I'm going to get right up over the top. so I can see. It should be the same dysfunction all the way along if it's an apparent leg length difference. So if this side is a little bit higher here, it's going to be a little bit higher here, it's going to be a little bit higher here, that tells us she's got a posterior left rotated ilium. We'll cover that next semester, okay? So that's an apparent leg length test. Roll to your stomach. Eli's test. Eli's test is a length test for the rectus femoris. So if I had you do a Thomas test and you didn't bend your knee to 70 to 80 degrees, I would go to Eli's test, which is this. And all we're doing is stabilizing, bending your knee. Again, there's not a necessarily measurement here we're looking for. Obviously, if you can touch your heel to your butt, that's full, but we're comparing opposite sides. It's nice because you can measure it. All right, where are you at? 120, 130, 145 degrees. Now we'll stand up. Trendelenburg test is our last test. We're going to have you face that direction. And all she's going to do is we're going to watch for a pelvic drop on the side that she lifts. So we're doing a lift off, and what we're looking for is that to happen. If that happens, that means this side is weak. So we're testing the side that she's standing on, but we're watching for the opposite side to drop. So stand on your right side. Yeah, perfect. So when she stands on her right, there was no observable drop, so that's a negative test. Perfect. If they need to, they can hold on for balance. We're going to try to minimize, you can have a seat. We're going to try to minimize the amount of balance. That's why we have people walk with a walker, so they don't have a Trendelenburg, or that's how come we have them walk with the crutch. So if I'm really standing like this, I might not drop, especially if I do it like this, because I'm holding myself up from dropping, okay? Again, you have to consider balance. Would I do a Trendelenburg test immediately after a hip replacement? No, because they're going to have a positive Trendelenburg. It's not, it's easy. Again, this would be a test that I was at a different time, all right? So it's not you don't have to do special tests every situation, all right? Let's do those 5 special